So would perfusion be different with either one of those two models, with a banging on the endothelial model versus stagnation in the CNS parenchyma? Would you predict a different perfusion pattern?
Well, actually, they could be related to each other. So if there is some back pressure, if the venous flow can't find its way out through the normal pathways, and we have, in some cases seen reduced flow out the straight sinus, for example, in that case, the venous blood will find its way out through the other plexuses in the brain and in the spine. And that is an awkward pathway. It's a more inefficient pathway. And so that could be leading to a reduced outflow in that part of the brain, and therefore a reduced inflow because of that. So that would then end up having both components in it. Yeah. It would have potentially this reflux effect or this increased pressure on the venous wall. It's believed by some people that that venule wall, the tiny veins before they become larger, they're the most susceptible to that damage. And at the same time, you may have a perfusion effect going on, and if you have reduced perfusion to tissue for too long, that tissue becomes ischemic. It doesn't have enough oxygen associated with it. And if it's ischemic for too long, then it may die. So then you would get necrotic tissue or scarring or something like this. So I think the role of these two may be interlinked together.
Yeah, the term I have seen, especially thinking about oligodendrocytes, is oxidative stress. Is that the same? To me, ischemia as a neurologist, I think of ischemia as an acute event. An embolus goes up into an artery and causes acute ischemia, whereas I don't think of chronic ischemia. It's sort of a truism in neurology that you never get a stroke from fainting, right? So obviously blood is leaving your head to the point where you're going unconscious, but you never get a stroke from that. So it's sort of the lore in neurology that ischemic is a localized arterial sudden blockage, whereas we're describing a whole new pathology that's never really been talked about before. Except for varicose veins, we've never really discussed the idea that venous insufficiency would cause not acute clinical abnormalities, but these subtler ones that take much longer to happen. So that's very appealing to me as a model for MS. As you know, when Devin was diagnosed, I went back and looked at the literature, and I thought, geez, the viral theory and the autoimmune theory, they have not been validated. And then I looked at the drugs that Devin was being put on, and I thought, geez, they're marginally effective. The British medical group threatened to stop paying for them. They thought they were so ineffective. So then when I heard about this model, it made great sense to me. It's still a little bit of a mystery why my neurological colleagues don't think it makes sense. To me, it makes very good sense that you need your brain parenchyma to be cleansed, to be flowing properly. And yes, of course, the pathology is not. We don't really care what the jugular veins look like. We care what's going on in the venules and the brain parenchyma up in the head. So I think my fMRI model is trying to look at that with the venous undershoot. But I'm particularly excited about this perfusion idea, because then we'd be able to see directly the result in the brain of these abnormalities we're seeing peripherally in the neck.
David, I think it's important that if people do these double-blinded studies, that they're going to tell the patients that some of them will get a sham treatment and some of them will get the treatment. But the idea behind this is that 3 months later, if something serious is found to be wrong with those who got the sham treatment, that they will in fact be brought back and treated. So I think that's reasonably long enough to determine if something real has happened for these people and something neurologically beneficial has happened for them. And yet it's short enough that they know they don't have to wait a year or 2 years in order to be treated. I think it's also important for the neurological community who is pushing the double-blinded concept to realize that it would not have been easy to come up with a good design for a double-blinded study without having these observational data that we do today. So the fact that well over 1,000 people have been imaged today means we have a better idea what to look for. And I wouldn't be surprised to find that if we have maybe on the order of, say, 20 different types of CCSVI, and you need 50 patients per type, you're going to need about 1,000 patients to design this. And so you need to know what or how to subcategorize that type of CCSVI in order to properly design the double-blinded study in the first place. So I think we're much more prepared to be able to handle that, and I think the registry that you have got started here will give people an opportunity now to follow people pre- and post-treatment, and I think that the use of MRI is going to open the door to investigating the very important questions on how people are changing pre- and post-treatment, to investigating cerebral blood flow, for example, and to look at how flow is changing generally over time for these people. And also, most importantly for them, are the lesions staying constant or going away? Is the iron staying constant or going away? All of this can be monitored if you collect the MR data before and after treatment.